Okay. Oh, great. Uh-oh.
Mama.
In progress.
Downloading all of your apps. Almost
Good evening, everyone, and welcome to the Promoting Mental Health in Adolescents and Adults with Down Syndrome. We're pleased tonight to have Dr. Brian Chicoine presenting to both the Down Syndrome Association of Delaware families and the Chesapeake Down Syndrome Parent Group families. I will turn it over to him and we'll get started. Thanks for joining us.
Thank you very much, and thank you for inviting me here this evening. It's a pleasure to be here. So it was mentioned we're going to address mental health in adolescents and adults with Down syndrome. And first, I want to just introduce you a little bit who I am and who we are. I am the medical director of the Advocate Medical Group Adult Down Syndrome Center. It's in Park Ridge, Illinois, a Chicago suburb. And our clinic opened in 1992 at the request of our local parent group when they were finding that their children were getting good care as children, but not getting the same quality of care as adults. And so we opened initially, started seeing people 18 and above, and now it's after several years, we went down to 12 years of age. And we use a team approach to try to address both, or really all physical, mental, and social health issues. Since we opened in 1992, we've seen over 6,000 adolescents and adults with Down syndrome, and we have about 7,000 patient encounters a year. So it's a busy place. Now, I want to leave a lot of time for questions at the end, and also want to provide as much information as I can, but certainly even in an hour and a half, there's just no way that I can present everything that all the information that you might find helpful or certainly that we know. So I just right up front will direct you to our online resources library. It contains videos, articles, booklets, and on a variety of topics. And we are continuing to develop more information all the time. We also have a contact form within the in that page or in that website that if you have additional questions that are not answered within the materials there, that you're welcome to send us a question and we will answer that. Again, the resources are being continuously updated. Just as a reminder this evening, and really for our information online as well, this information is provided for educational purposes only and is not intended to serve as a substitute for your medical, psychiatric, mental health, or behavioral providers, in both in evaluation, diagnosis, and treatment. So certainly you're welcome to bring this information to them, but certainly please don't use this in place of them. So I'm going to focus tonight on the common characteristics, the interaction of physical, mental, and social health, promoting mental health, common mental health conditions, and then some case examples. And then again, I'll try to leave a lot of time for questions at the end. So common characteristics is a very important topic to consider, really, when considering a person with Down syndrome across the board, but certainly with regards to mental health. Some of these things are very important to understand as you're addressing mental health issues. So often these, what I'm going to talk about, are not in and of themselves a mental illness or a symptom of mental illness, but a change can indicate that there is either a mental illness or some sort of physical or social stressor going on. So important to understand these. And oftentimes it's important to understand these, that oftentimes we consider this as normal. And so that's an important feature as well, or fact as well. So one thing we know about the people with Down syndrome that we have seen, and I should just say, as we talk about common characteristics, there is a saying in the Down syndrome community that if you know one person with Down syndrome, you know one person with Down syndrome. And I think that's an important thing to remember. And we like to say that if you know 6,000 people with Down syndrome, you only know 6,000 people with Down syndrome. And really what we mean by that is that each individual is an individual. Each individual has their own personal genetics, as well as family history and family dynamics, et cetera. Certainly there's the extra chromosome typically that is associated with Down syndrome, obviously, but again, each individual is an individual. So these are common characteristics, but these are certainly not meant to be looked at as universals, and certainly not looked at that the person with Down syndrome that is definitely going to have them. Although we do commonly get people will commonly say it's almost like you know my son or daughter. because again, these things are common, but again, not universal. So let's start with the first one, strong visual memory. We find that people with Down syndrome typically have a stronger visual memory than auditory memory or auditory learning. And they often are good at remembering visual data. Some people have a very strong spatial memory where they can remember spaces, directions, how to get from one place to the other. Very strong in many people with Down syndrome. In some individuals, we like to say they don't have photographic memory, they have videographic memory. They can almost, as if they're replaying an event, almost like flipping a switch on the recorder, or on the whatever the latest technology is at this point. But they can just flip it on and replay the memory as if you're almost replaying a video. These can all be very positive things. Sometimes it does get people in trouble from a sense of many people with Down syndrome have a limited sense of the understanding of time in chronological order. And so an event that happened yesterday or several months ago or years ago, there may be some confusion, or at least some way of the person words it, that it sounds like they're replaying something that happened yesterday, when in fact they're talking about something that happened a long time ago. And you may be able to think of situations where that could be a problem. And then the other thing is memories are often experienced as if they're happening now. So we often wondered if that doesn't lead to more post-traumatic stress disorder, because people can have remember even negative memories from long ago and keep replaying them. In a study we did and looking at our mental health, we did not find that post-traumatic stress disorder was more common. However, we do suspect that we often don't hear what the stressor was, and so we may not understand that it's post-traumatic stress, where really it ends up just getting diagnosed with as anxiety or depression or something similar. And so we don't really, it's a post-traumatic stress, but we just don't understand what the stressor was and understand the post-trauma component of that. The other thing that's a very important characteristic to understand is self-talk and imaginary friends. So this, when we started the clinic almost 30 years ago, we were seeing lots of folks that were coming in on antipsychotic medications. And we were kind of mystified in how many people were being treated for psychoses when we thought that it was less common, although in our study, it may be a little more common. But nevertheless, it just seemed to be an inordinate amount of people being treated with an antipsychotic medication. And so we began to dig into this a little bit, and it really looked like what we would call developmental stage appropriate behavior. And by that we mean, we know that children talk to themselves as part of problem solving and dealing with stress or dealing with scolding or whatever the case may be. And so that's a common developmental stage appropriate behavior where over time, many of us will do that internally or silently. Many people with Down syndrome continue to do it out loud. And so at that time, we thought that was the main issue. We also really looked at it as a coping strategy and something that could be used when people are bored. So they can almost like replay, like we just talked about a minute ago, those videographic memories, they can replay things and then speak about them out loud, and sometimes even recite what some folks are doing is reciting a movie or an event or whatever out loud. We now know that actually additional literature came out over time that many athletes will talk to themselves as sort of a motivational tool. And then also it's now clear that many people without Down syndrome with no developmental disability talk to ourselves, including me, and that really is not looked at as an abnormality. In a lot of ways, it ends up becoming a social skill rather than an abnormal psychological feature, in that it's probably not the best idea to sit on the back of a Chicago city bus and talk to yourself, because that gets frowned upon. But certainly in the privacy of your own bedroom, that's acceptable. So again, that's more of a social skill than a psychological problem. And then the other thing with self-talk, we certainly see a change in quality or frequency of maybe a sign of stress or mental illness. So if I've had a rough day and I go home and I'm kind of thinking through my day, and maybe someone angered me and I'm sort of speaking angrily to that person, to myself, that would be comparable to many of our patients that would go home and in a similar situation talk out loud to themselves and do it. And over time, we see some people develop increased frequency, a change in the quality. So it may become more angry, it may become more self-flagellating. And in some cases, people that understood sort of the social skills component of this, where it may or may not be acceptable, if you will. And so they lose that skill and then they're doing it, wherever. And so that can be a concern. So in and of itself, we don't see self-talk as a bad thing. But it can be, if there's a change, it's something we certainly want to look at as is there mental illness or perhaps a physical change or a social change that is causing pressure on the individual and causing them to have change in their self-talk. Imaginary friends are sort of in the same category to some degree. And again, developmentally stage appropriate, kind of a coping strategy or boredom. And a lot of people will talk to imaginary friends, and certainly we do know that children will do that as well. So that's not atypical for many of our people we see. And again, with a change, that can be concerning. So if someone is, able to, have some imaginary friends and then, move on and participate in their day and do all sorts of other things, that in and of itself is not a concern. But if the person is so stuck on these imaginary friends and can't do anything else and won't leave their room and can't sleep and can't eat and whatnot, that certainly is a change, and that's certainly concerning and something that will need to be addressed. The next thing is what we call the groove, and that's the tendency towards sameness or repetition. So many people with Down syndrome like to do things the same or repetitiously, or they might like to watch a movie over and over or listen to the same song. And so that's a common tendency of many individuals with Down syndrome. It can be very functional. It can be very functional in employment, in jobs that do need repetition and to be done the same each time. It can be very functional, and as long with the right training, the skills of a person with Down syndrome can really be beneficial in those job settings. It can certainly become very problematic when people really get stuck. Perhaps you might call that a rut instead of a groove, where the person is so stuck on doing that over and over that they may not be able to sleep, they may not be able to eat, they may not want to go to school, they may get very stuck and just get really unable to move forward. We'll talk about obsessive compulsive disorder a little later, but there is a relationship between these two. We recently did a webinar on the groove in people with Down syndrome, and so when you get these slides, if you click on there, you can see that webinar, and then we also have an article on in our resource library that I mentioned a moment ago. So as you look at those three things we just talked about, and any other behavior that a person with Down, we all have behavior. Questions whether it's challenging to those around us or is problematic for ourselves. But really, any and all behavioral change should be viewed as a possible communication tool. So that's whether that's a change in self-talk, whether that's someone is getting upset. And so what is the person trying to tell us? Now, again, because of communication issues in some individuals, they have difficulty with their expressive language, or they have a difficulty sharing their emotions or what's bothering them. Things may come out with a behavioral change rather than something that is said. And so we really want to look at that as a potential communication tool. And again, that might be a mental health issue, that might be a social stressor, or that could be a physical health issue. And I'll give you some examples, and then I suspect you'll have some as well when we get to the Q&A. But again, I give lots of presentations to residents and medical students, and I say if there's one slide you're going to really pay attention to as far as understanding caring for people with Down syndrome, this is the one. We do see about 40% of people with Down syndrome have some sort of mental health or behavioral challenge. And it is very, very important not to only wear your psychiatric hat when approaching those. You really want to look at the physical health issues, the social stressors, as well as the mental health issues, and what may be affecting that individual and what may be changing this behavior. And again, because of communication issues, even though I know this and I do this every day, because of communication challenges and trying to figure out what's bothering people, it is not difficult, unfortunately, to miss some of these underlying conditions, and you got to keep digging and keep looking to see see if you can find things that may be contributing to the behavioral change. So the behavior, change in behavior as a sign of communication is the first most important thing. And then here's the second most important thing, is the interaction of physical, mental, and social health. And this is so important to understand this. So first off, we'll start with what is health, and we like the World Health Organization definition of that: health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And so really looking at physical, mental, and social well-being are very important. And again, you'll hear me say that over and over. And so these are very intertwined. Physical health can affect mental health, and social health can affect physical health, and social health can affect mental health. So this is really an intertwined, and really trying to understand all three of these and how it impacts the individual, and then how it impacts also whatever condition that you're, or symptom or whatever that you're trying to assess. So physical health issues that can affect mental illness, there's so many. It might be a sleep disturbance, it might be thyroid problems, which are more common in people with Down syndrome. It could be something as simple as dehydration. We know that many people with Down syndrome don't seem to drink enough fluids. It can be gastrointestinal problems. Celiac disease is more common. Ulcers, intestinal blockage, all these things are more common, and many others. And so those are all things we have to consider when we're approaching somebody with a behavioral change or mental health concern. And then certainly social health issues that can affect mental illness, or mental wellness, whether that's conflicts at school or work, aging out of school. That's such a big one. As people get, in Illinois, school goes till age 22. And as people age out of the school system, how challenging that can be for some people. Leaving a job, or a sibling moving out, or getting married, or whatever. Those can be very challenging situations for people with Down syndrome, and so many others that need to be considered when assessing somebody for a change. Unfortunately, we have seen all these things sort of get thrown together in one, sort of revolving around one situation during the last year and a half plus due to COVID-19. So certainly changes in routine, the grief and loss, people passing away, or loss of jobs, all those things contribute. Social isolation has been an issue. Family and personal illness, people actually getting COVID, and family members getting COVID. News overdose, just the constant barrage of information about COVID that comes out. If people are feeling stressed, we see them just sort of turn off that TV and the radio or whatever for a little while, and talk about something else. Don't talk about COVID. It is so amazing how many of our patients, the people that we see with Down syndrome, that are really absorbing all this. They're watching and they're listening, and it is just amazing, for me to hear what some of our patients come to the office and tell me about COVID. It's a lot of our patients are really getting this, and they understand, and are feeling the stress of it. Changes in diet. A lot of people sitting around and 10 feet from the kitchen, where they're used to being over at work, or recreational activities, whatever the case may be, and so they're eating differently. Certainly, family stress. Lots of stress on families. So loss of jobs and things like that. And as this has gone on, and then certainly the lack of physical activity. And then certainly the illness itself, the COVID-19, individuals with Down syndrome who have gotten COVID-19, and how stressful that so many of these things have been for individuals with Down syndrome. Oh, sorry, one other thing. So really, when you're looking at this, and we go back to that previous slide about the interaction between mental and physical and social health, they really have to consider all those aspects of the person's, of the person, because to only address one, you're likely to perhaps miss something, but also probably undershoot with ability to treat what's going on. And so if you aren't treating all the issues, the person may not develop optimal health at some point. So how do we promote mental wellness? So certainly again, you'll see a lot of physical issues. Again, this intertwining between physical and mental health, and I'll keep harping on that because it's so important. Good sleep, healthy eating, regular exercise and physical activity, stress management, employment, recreation, social opportunities. All these things are important to promote an individual's mental wellness. Good sleep, again, we put this first. It's not by accident that this is first. It is so important. And we do know a lot of people with Down syndrome have sleep challenges. There's certainly sleep apnea is more common, but just abnormal sleep is more common in people with Down syndrome and other intellectual disabilities. Starting with good sleep hygiene is so important. We have some visuals on our resource library that can help individuals try to develop a good bedtime routines. And again, a routine, individuals that do tend to like routines and do tend to live off routines, to have a routine can be soothing and calming and actually help them go to sleep. So good sleep hygiene is so important. You want to review the current medications. There's a number of medications that can alter sleep. And maybe, when you take the medication may be part of the issue. Maybe the medication's okay in and of itself, but when you take it may be a concern. We've had good success with a number of natural products to help with sleep, melatonin, magnesium in some individuals and some others. And then there's other prescription medications that you can talk to your healthcare provider about. We recently gave a webinar on sleep in adolescents and adults with Down syndrome, and that's available again on our resource library. And then other resources and for the visual handouts are available on our resource library as well. I should have mentioned one other thing. Again, some medications may affect sleep negatively too. So that's not only what might positively affect sleep, but what could negatively impact sleep. And again, so next is healthy eating. Again, it's so important with helping people have good mental health. Again, it's a physical health issue primarily, we think of it, but it certainly impacts the mental health issues as well. So good hydration, balanced meals, all the food groups, portion control, portion size, limiting processed foods and pop and soda. So many of the people we see are so enamored by pop or soda, and trying to encourage them to drink other things is can be challenging, but can help them feel better in some situations. And again, small changes add up. It doesn't have to be 100%, 180 degree or 100% change in the diet overnight. Small changes do benefit over time. We have quite a bit of information on our resource library on healthy eating and ways that you can improve diet and looking at healthy portion sizes, variety of foods. So a number of things on our resource library that please feel free to take advantage of. And we have a number of videos. And I should mention the videos that are for people with Down syndrome. The actors and actresses all have Down syndrome. And so we have a number of videos on healthy eating and making good food selections that, again, the actors and actresses all have Down syndrome. So they're fun to watch. And people with Down syndrome do tend to focus in on those, I think, more when it's another person with Down syndrome speaking than they do with somebody else like myself. And then again, exercise and physical activity. Again, we might think of that more as promoting physical health, which it obviously does, but it certainly does promote mental health as well. So find what works for that individual. Make it fun, make it social. If it's drudgery, probably not going to do it all that long. And making it fun has been shown, at least in the non-Down syndrome population, to be probably the number one reason people continue to exercise. That may not be the reason they start, but it's often the reason they continue. Incorporate it throughout the day. Are there ways that you can change up the routine and just include more activity in the day? And then the other thing is go outdoors. Again, not repeated in folks with Down syndrome, but there's data that indicate that exercise outdoors can have actually more benefit in many ways than exercise indoors. So getting outside and taking a walk, or getting in the woods, or playing tennis, or whatever the case may be, just getting outside and being active can be so important. In a lot of ways, I say that so much, a lot of the benefit is just pushing that red button on the remote control and getting off the couch and getting started is so important. And there's, again, a lot of resources we have, and some that we've developed, and then we share others, resources that others have developed as well in our resource library. So lots of lots of information that can be shared and reviewed by the person with Down syndrome themselves. And again, when we talked about the groove, if we can help them get into a good groove with exercise, so many of our patients, do it so much more in a schedule and a routine and faithfully than many of the rest of the folks without Down syndrome. And really, once they get started, they do this very, very well. And how about managing stress? This is important. One of the health problems that people with Down syndrome have less of, and there are others, but one of the things that people with Down syndrome have less of, or is less frequent, is high blood pressure. And commonly, people will say, "Well, that's because they don't have any stress in their life," and that is absolutely not the case. Two things. One is people with Down syndrome do have stress in their life, and secondly, that's not why people don't have high blood pressure. There's a different issue. But anyway, so people with Down syndrome have stress in their life. Maybe for most it's not having to pay the mortgage or whatever, but they do have stress. And I like to say that stress is in the eye of the beholder. So what I find stressful, a person with Down syndrome might not, and what he or she finds stressful, I may not. So that's, but that doesn't negate the fact that he or she is stressed by that, nor that whatever I am stressed by that I am stressed by that. So it's in the eye of the beholder. So one thing is, we note that people with Down syndrome have what we call empathy radar or social sensitivity. So a lot of people with Down syndrome seem to just almost like, sense others' feelings or others' stressors. And so, stories of, I've heard many, many times, grandma's ill, but we haven't told him that grandma's ill, but he seems to be stressed nevertheless. And I say, well, two things. One is, so many of our folks with Down syndrome seem to hear from very far distances, things that perhaps they were not intended to hear. But secondly, I think a lot of times people with Down syndrome will pick up on the stress that you may be feeling from whatever the situation is. And so there's really what we call an empathy radar. And I mean, I've said it can have a real positive. They can respond to, if I'm feeling poorly and the person with Down syndrome senses that and comforts me, that's wonderful. On the other hand, they may absorb other people's stress and then feel distressed themselves, and how that can have a negative impact. So as much as possible, we encourage trying to provide in the moment support when possible. So if the person is expressing that they're stressed, rather than saying, we're going to schedule a time to talk, 2 weeks from now and at 3:00 on a Friday afternoon, you want to try to pause if at all possible and deal with it in the moment. And then certainly, some of this is beyond us, and so really trying to work with a mental health provider as well. And some of that may be talk therapy for some individuals, but other therapies as well, such as music or art and other things that people that can be very beneficial for people with Down syndrome or other intellectual disabilities. We had two women with Down syndrome do a wonderful video on how to manage stress. And we have a handout there as well. You can see the two ladies there on the left. And then we have other information about ways to manage stress that are in various handouts that we have on our webpage that you can share with your loved one with Down syndrome as ways to manage stress. For years, as we go into the past, people would come to me and said, "My son or daughter colors. Is that age appropriate?" And I said, I think that's really fine. I mean, I think that's okay. And then slowly but surely, the rest of the world caught up, and lots of adults now color as a form of relaxation or stress reduction. People with Down syndrome just led the way, and they've been doing it for a long, long time. And many people find that very relaxing. And then certainly employment, recreation, and social opportunities, sometimes harder to achieve, but really want involvement promotes physical, mental, and social health. You want to find options that match interests and skills. For some individuals that are, have had a mental health or mental illness or mental health challenge, it's going to take a safe reintroduction. I was just talking to a family today where the gentleman's had some significant anxiety, and he's slowly but surely getting back into activities. But we've talked about in the family is very aware that trying to get him to do too much too soon actually just makes him more anxious, and we end up with a retreat or significant going backwards. And so you're really kind of taking it step by step and reintroducing into what I call safe activities where they're less likely to cause stress or anxiety is important. Building this into visual schedules is very important. People with Down syndrome tend to be so visual, and these visual schedules can be so important and promote regular activity. The other thing you'll hear me talk a lot about visual supports or visual schedules or whatever. Many families over the course of time said, we used to do that when our son or daughter was a child, but we haven't done it recently. And our sense is that this is a lifelong, something that really benefits most people with Down syndrome lifelong. We all use sort of visual supports in one way or another. Many of us, we use our phones or iPads or whatever to support us, our tablets. And many people with Down syndrome are starting to use some of the technology as well. So, again, using some visual support that the person can use is kind of a prompter to do things that can be very helpful. Let's talk about, so we talked about some common characteristics, and we've talked about how we can promote health. Let's talk a little bit about common mental health conditions. What are some of the when things are not going well? What are some of the things we see? Somebody's not muted. If you could just take a peek, it might be good just to mute, because it sometimes can make it hard for others to hear. So what are some of the common mental health issues that we see? So we recently had published a study with, as you can see, there was about almost 6,100 people with Down syndrome. It was some children and adults, and about 30,000 controls. This came from the Advocate Healthcare System, of which we're part of. And so these controls were matched as well as we could for age and sex. There's something called odds ratio, which means, in this case, it's the cases versus the controls, meaning the people with Down syndrome, what percentage of the people with Down syndrome have it compared to the percentage of controls, people without Down syndrome that have it. And so anxiety was significantly more common, as was obsessive compulsive disorder. Even, obsessive compulsive disorder was 19 times more common. Mood disorders, schizophrenia, impulse control disorders, and then catatonia, which we'll talk about here in a second, is significantly more common, people with Down syndrome. And mood disorders would include depression, as well as bipolar. Now, there are, you may be aware of the book on the right there, the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition, or shortened DSM-5. That's sort of the it's American Psychiatric Association. It's sort of the diagnostic guru book, if you will, for mental health conditions in people in general, and that's certainly not specific to Down syndrome. It's used widely. And because of the challenges in using those criteria in people with intellectual disabilities, including Down syndrome, a kind of a companion book has been published, and that was in the 2nd edition, called the DMID, or the Diagnostic Manual for Intellectual Disability. And so if you look at the diagnosis criteria in the DMID-2 versus the DSM-5, the DMID-2 tends to be more observational and less self-report. So we do know that, again, many people with Down syndrome, other intellectual disabilities, find it difficult to self-report their symptoms, but family observing can see how those symptoms might be displayed, if you will. And so, again, family observation or other people observing the individual are really key and critical in making diagnoses and sharing that information with your provider. So let's just talk a little bit about some of the more common mental health conditions or mental illnesses that we see, and then I'm going to go to some case examples. So first is depression. So depression tends to be a persistent feelings of sadness and or decreased interest in things that an individual previously enjoyed. So that's such an important piece of a decreased interest in things that an individual previously enjoyed. And that's something that families will commonly observe and will share that information with us. So, he used to be so involved in Special Olympics basketball. Now he just has no interest. I should mention that people with Down syndrome do go through adolescence just like the rest of us. So we have to kind of be careful not to overdiagnose adolescents. So for example, someone will come in and say, my son is spending a lot of time in his room, listening to music, talking to his friends on the phone, and not wanting to talk to mom and dad. And the first comment I usually ask is, do you have older siblings? Does he have older siblings or she have older siblings? And were they teenagers at one point? And that's something that often kind of turns the light bulb on that, yes, looks very similar to their other sons and daughters as they went through the teen and adolescent years. And it is important to realize that adolescence in people with Down syndrome can be delayed. And so it may be at an older age that it would be in somebody else. But certainly, so just routine, if you will, teenageism or adolescence is not depression, but certainly there are times where it's clearly significantly beyond that. And then certainly we're looking at the diagnosis of depression. And those symptoms would be depressed or irritable mood, again, loss of interest or pleasure in activities, it can be weight loss or gain, change in sleep patterns, slowing down of physical movement or restlessness. So either slowing down or sort of agitated or moving more, fatigue, feelings of worthlessness, although that one's a tough one to get an individual with Down syndrome to say, even if they are feeling it. Decreased concentration. Again, that's oftentimes something observed rather than something reported. Recurrent thoughts of death. Again, I don't hear this one very often. Sometimes there's psychotic features with extreme withdrawal, hallucinatory self-talk like behavior, and others. Inappropriate fears or avoidance of people or things. And then sometimes it's associated with a strong refusal to leave the home. As we treat depression, this last one, strong refusal to leave the home, is in many people the last thing to get better. And again, we talked about sort of slowly reintroducing people into activities. And that's where this one is so key to not to trigger the recurrence of symptoms. People will often ask me, well, give me the specific roadmap to slowly reintroduction to activities. Unfortunately, that I can't. Not that I won't, I can't. Because first off, the individual better than I do, and you're there in the situation. So you just kind of keep assessing each day. Oh, maybe I see that I pushed a little too hard there. Maybe not. I could have pushed a little more there. And just trying to assess it as you take each day as it goes. But again, trying to do it in a safe, not too fast, back to activity in some individuals is very helpful. For depression, again, it may be counseling. Some of our individuals can definitely participate in counseling, and we recommend that when that's appropriate. And then some other times it may be, therapies that are, again, we talked a bit ago about music therapy or art therapy or whatever the case may be for that individual that may be helpful. Again, finding the right provider to do that is key. Try to identify and reduce whatever stress is going on. Again, we talked about with COVID and the news overload, that would be one way to reduce the stress by turning off the TV some of the time. Establishing healthy eating, sleeping, and exercise routines. We certainly talked a great deal about that. Encourage participation in affirming social activities. Again, try to reintroduce in a fashion that the person is able to manage, but this becomes part of the treatment as well as part of the cure, if you will, in a sense, or part of the benefit of cure. In other words, so being able to participate in affirming social activities is part of the goal of treatment, but it also becomes part of the treatment in the sense that as an individual begins to participate again, that's self-rewarding by itself, in and of itself, or that's rewarding in and of itself. And so as the person does something that they previously enjoyed and start to enjoy it again, that is its own encouragement to keep doing it and to do it more regularly. Again, be cautious to watch and see that it's not going too far too fast. And then certainly medications, there's a variety of antidepressants that can be used. Most commonly, it would be the selective serotonin reuptake inhibitors, things like sertraline, and then the serotonin norepinephrine reuptake inhibitors. And there's a variety of those as well. But there's a number of other medications, which we won't go into specifics right here. Another common condition is anxiety that we see in individuals with Down syndrome. And that it really is anxiety that interferes with day-to-day life on a long-term basis. And so really the interference is an important thing to consider. So really for all mental illness, there's a degree, how much does it impair the individual? And then how much does it impair those around them? And so really those are two key things to consider when looking at a change in behavior or mental illness. So again, just as in others, symptoms of feeling worried or anxious on most days. Sometimes you see some mild self-injurious behavior. Sometimes a person just becomes easily fatigued. It's just life is stressful and it's just hard to keep going. There may be difficulty sleeping. Certainly during COVID, we've seen lots of that. Restlessness, difficulty concentrating, muscle tension, irritability, all symptoms of anxiety. And again, that may more than self-report. Oftentimes that is expressed with a behavioral change or something that someone else would observe. There's a lot of physical health problems that can contribute to anxiety. Probably the leading one is an overactive thyroid or hyperthyroidism. So certainly want to be assessing for that. Again, counseling in a variety of ways, calming strategies and relaxation techniques and sensory approaches. We have a lot of information on our resource library, online library about calming strategies, relaxation techniques, and sensory approaches. Dr. Frank, our occupational therapist, has put a lot of information up about sensory approaches to individuals to help them relax. So even in those individuals that we wouldn't really think of as having a sensory deficit or a sensory impairment, many of those sensory approaches really are helpful to any of us, including people with Down syndrome. For example, I saw a gentleman today that really doesn't have a diagnosable disorder, but he certainly became very anxious anytime he had to draw blood. And a couple of years ago, Dr. Frank did some sensory approaches with him and some ways that helped relax him. And he walked right over and stuck out his arm and got blood drawn that day after having been so resistant for so long. And that actually has persisted. After today's appointment, he went right over and got his blood drawn. Medications may be used for anxiety, including benzodiazepines. There's what are called non-benzodiazepine anxiolytics, antidepressants. And so there's a variety of natural products that can be used that can help with anxiety in some situations. And then next is obsessive compulsive disorder. And this is, again, something we see pretty frequently in our practice. And really we kind of tie it to the groove in many people. So obsessions are persistent thoughts or thoughts that preoccupy the mind. And then compulsions are repetitive behaviors or acts that one feels compelled to perform. So in the non-Down syndrome population, a common one is hand washing. So the obsession might be, that my hands are dirty or germy or whatever all the time. And the compulsion would be just this repetitively going to the sink and washing one's hands over and over and over. Interestingly, that's not a compulsion we commonly see in people with Down syndrome. It's sort of a very classic one in the non-Down syndrome population, but it's not something we see very commonly in people with Down syndrome. It can impair function and it can limit opportunities. So years ago, we saw a gentleman that was very obsessed with making sure that the home he lived in at a residential facility was clean. And overnight, the staff would, after getting everyone in bed, would had some cleaning responsibilities, and he felt obliged to stay up and to monitor them to make sure they were doing a good job with the cleaning. And so, that it became clearly impaired his function because he was up all night not sleeping and then had difficulty managing things the next day and then became irritable, et cetera. So that was clearly that was a groove about keeping things clean that went awry. And then limited his opportunities. The next day he could participate in other activities. So in the non-Down syndrome population, oftentimes obsessive compulsive disorder, one of the big challenges or features of it is that the person is upset by the behaviors and thoughts. So the person doesn't want to wash their hands repeatedly, but just is so compelled to do so and gets upset or angry that they have to do it. We don't see that commonly in people with Down syndrome. That would not typically be what we see. Now, it may be upsetting or problematic or challenging for the family, but not typically for the person with Down syndrome in the same way as it might be for someone without Down syndrome. It can be problematic, however, when the individual may get upset if the behaviors, thoughts are blocked or prevented. So, in the gentleman that was needing to clean when they were trying to put him to bed, so you don't need to supervise. He got very angry and upset, and that became a real challenge. So, if you're trying to block that compulsion, oftentimes makes the person very anxious, and oftentimes then can cause a behavioral change. And the other thing that tends to be a problem with people with Down syndrome is the person cannot participate in the usual activities due to, in a sense, being stuck. So, again, this gentleman is just going with this example. He's up all night, and then he's tired the next day, and he can't participate. Or, some individuals just are doing something in the room, and they do it over and over and over and over, and they can't come out, they can't get to school, they can't get to work on time, whatever the case may be. So the person gets stuck. So that would be where it's more typically becomes problematic in people with Down syndrome. Again, there's a lot of non-medicinal strategies, and we talked about our video on the groove, and then Dr. Frank has a lot of non-medicinal strategies in there. I'd encourage you to take a look at. Sometimes medications become indicated. And again, with all the conditions we talked about, a typical approach in people with Down syndrome is to do what we call start low and go slow, which means oftentimes a person with Down syndrome will respond to a low dose of a medication, where someone else without Down syndrome may require a much higher dose. Oftentimes people with Down syndrome will respond to a low dose, but not always. And so you may need to go up as you continue to monitor symptoms, and then go slow. Allow people with Down syndrome, we just slowly increase until we get to a point where it's beneficial without causing undue side effects. Sometimes the treatment does need more than one medication, and again, not just for OCD, but for any mental health issue. And for OCD, the medications may be antidepressants, anti-anxiety medications, benzodiazepines, like the Valium-like medications, or Ativan or lorazepam. And then sometimes mood stabilizers. If the person gets very agitated, we may end up using something to try to help with the mood, to stabilize the mood or the agitation. One more thing I want to talk a little bit about is when an individual has decline in skills or regression. So I'm going to shift gears here to the next topic. We've talked about depression, anxiety, and OCD. Now I want to talk about decline in skills or regression. So this is not one entity. This is sort of, why do people with Down syndrome potentially lose skills or regress? So again, a key to this is a decreased ability to perform or use previously mastered skills or abilities. In this, we may see cognitive changes, we may see behavioral or psychological changes, we may see challenges in the ability to perform activities of daily living. There may be change in motor function, there may be change in speech. There can be a lot of different ways that a person can lose skills. And there can be many reasons for this. These are some of the things that are, some of them tend to be more common in people with Down syndrome: medication, sleep apnea, seizure, B12 deficiency, thyroid changes, lots of things, chronic pain, lots of reasons people with Down syndrome might decline. It can be heart disease. Particularly years ago when we first started the clinic, we saw a number of people that had congenital heart disease that had not been surgically corrected at infancy and had developed severe heart problems as they got into adulthood. It may be a stroke or neuropsychiatric disorders. We talked briefly about catatonia, mood disorders, depression, OCD, psychotic disorders. Lots of reasons that people with Down syndrome can decline. And just that, again, that's not unique to Down syndrome at all. That's true for many of us, that with a change in a medical condition or a psychological condition, we may not function as well as we did previously. There may be infectious diseases, bladder infections, pneumonia, sepsis, Lyme's disease, a variety of medical conditions, again, that can, infectious disease conditions, I'm sorry, that can cause this. There may be toxic metabolic concerns, sensory concerns, vision changes, so important, hearing changes, so important when it comes to with regards to a person with Down syndrome's level of function. Just for example, we had a gentleman that developed this dense cataracts and was thought to have developed Alzheimer's disease, and treating his, having surgery to correct the cataracts, in a sense cured his Alzheimer's disease. Obviously, he didn't have it, but so again, making sure we're looking at why is a person with Down syndrome declining, and what can we do that's potentially reversible. And then adjustment to life events. We talked a little bit about this before, but transitions in relationships and loss of family, friends, pets, school graduation, work setting changes, physical relocation, response to hospitalization or medical conditions. And then again, obviously all the things we talked about with COVID-19 that have been so challenging for so many. And this one is still kind of a work in progress. What is the impact of autoimmune disorders on the brain, and how much of that is related to the inflammation and the changes in the brain related to these autoimmune disorders? And that's information. These things are still being sorted out, and what exactly that means. There is something that goes by a lot of different names. We use the term regression syndrome. It's but also been called Down syndrome disintegrated disorder. It's also been called idiopathic regression syndrome. It's also been called Down syndrome regression syndrome. So it goes by lots of names. And what that tells us is that there isn't one agreed upon name. So it isn't a definitive condition, if you will, at this point. It's not defined. It does occur in some people with Down syndrome. It's not common, but it's not uncommon either. And this is something that I'm a member of the Down syndrome medical interest group, and this is something we're working on trying to get a better understanding of. And you may have heard of this, or you may know someone, or your own son or daughter may have a regression syndrome. But it's evidenced by declining cognitive symptoms, or declining cognitive or executive function, social withdrawal, loss of acquired skills. So again, important, the skills that the person previously had, but now does not display. Loss of functional use of language is common. It generally lasts more than 3 months, although the reason the asterisks are there is that for some people, getting treatment started as soon as possible can make a significant impact on treatment as well as speed of recovery. So certainly don't wait 3 months to treat it if appropriate. Typically, it's age range of 15 to 30. But it can certainly, there are some younger and some older, but that would be a typical age range. And there's a number of other features: maladaptive behavior, psychiatric symptoms, a failure to acquire new skills, inattention or disorganization, motor slowing, and sometimes vegetative, what are called vegetative symptoms, appetite, weight loss, incontinence, sleep pattern disturbance. There's really a lot we don't know about this. There's a lot of unknowns. But so again, sorting through this, looking at what are some of the underlying causes. Again, we talked about a whole host of potentially underlying medical problems or psychiatric problems that can contribute to a change in a person and may contribute to this regression syndrome as well. And so that we need to look at those and see if those are contributing. There is one condition called catatonia that is sometimes associated with regression, and it's an abnormality of movement and behavior. It can, but it's not always associated with a mental illness. Historically, it was thought to always be associated with schizophrenia, but then they thought, well, there's other mental illnesses, and now there's some that think that it can actually occur independently of any mental illness. It can have various presentations, including repetitive or purposeless overactivity. So a lot of people with Down syndrome who have catatonia will kind of move nonstop. It's often their hands, repetition movement of their hands, for example. But on the other hand, on the exact opposite, it can also be resistance to movement. So they're almost kind of frozen or stuck, kind of more what we would sort of more classically think of as catatonia, or being catatonic. But again, it's really a motor change in motor function. So it can either be increase or decrease in motor function for catatonia. Treatment, first, you certainly want to look at diagnosable conditions. Again, we talked about many things: thyroid, catatonia, autoimmune, sleep apnea when we're looking at regression. We want to treat related signs and symptoms. What are the particular? Many times it's psychiatric symptoms, or maybe sleep. We may want to use therapies to help improve function, get people functioning again. And again, I keep going back to this, but starting with safe activities to get people going again. There may be depression associated with hypothyroidism, so they may end up needing, and that's one of the symptoms of hypothyroidism can be depression in some individuals, and so they may need thyroid medication, levothyroxine, as well as an antidepressant. So there may be multiple ways that this has to be addressed. And again, we want to treat the associated symptoms that come with regression. So there may be depression, anxiety, agitation, sleep challenges, all things we've talked a little bit before. And then medication choices are influenced by patient's particular symptoms and the particular effects and side effects of the medication. For example, there's an antidepressant called mirtazapine, which is a very nice antidepressant, but also tends to increase appetite and help people sleep. So that one's given in the evening, for example. So someone with depression with a decreased appetite and poor sleep, or not having difficulty sleeping, mirtazapine might be the right choice. And someone who's eating constantly as part of their depression, mirtazapine would not be the right choice in that situation. Sometimes these changes are associated with pain, and duloxetine, which is an antidepressant and an anti-anxiety medication that also helps some individuals with pain management. Sometimes people will have depression with increased appetite, as I mentioned, and bupropion or Wellbutrin is probably the antidepressant, at least in our experience, that has the least increase in appetite, and in some situations actually helps decrease appetite. There may be the agitation for which an anti-seizure medication may help, or an antipsychotic at times. So again, it's very important as families that you observe and report the symptoms, and that's a key to assisting with medication selection. So in the last few minutes before we jump to questions, I want to just kind of open sort of questions by presenting a few cases that you may have similar situations that you'd like to talk about. So let's do case one. It is an 18-year-old man was putting his head on his desk at school and not participating in class activities. The teacher was concerned that there was concern both by family and teacher and others that he was depressed, and an appointment was scheduled with us. On the exam, we noted, in addition to this history, we also noted on the physical exam that he had increased reflexes on the physical exam, and an X-ray was ordered that showed he had atlantoaxial subluxation, which is the slippage of the first vertebrae on the second, which those are the X-rays that are typically ordered, or at least in the past, were ordered for Special Olympics. And so the situation in his case, he was not depressed. In a sense, his neck was so loose, his head was so loose that he was having a hard time holding his head up throughout the school day. And so his treatment was not an antidepressant, but his treatment was getting an MRI of his cervical spine and having him see ortho spine surgery and neurosurgery. And then he had surgery that ended up solving this problem. So again, we talked about changing behavior as a potential communication. In this situation, there was a communication of a cervical spine problem. So we have to be careful not to overinterpret behavioral changes as only behavioral changes and not look into the why or look into what may be the underlying potential other health problems. Another case, a 29-year-old woman developed distorted thought processes that involved intertwining real-world events with TV shows and movies. She had lost interest in activities she previously enjoyed. She had a regression of skills. And this had occurred acutely after her sister left for college. So this was very disturbing to the woman. It prevented her from participating in activities. We diagnosed her with depression with psychotic features, and she started an antidepressant and an antipsychotic and had a dramatic response to treatment. Again, with a reintroduction into activities and kind of steering her away from some of these TV shows that she was getting so lost in. We were able to help her get back to a previous level of function. Just as an aside or an additional word on sort of related to the groove. So when people are stuck on something like she was with these TV shows and movies, we typically find that it's more, not only easier, but more beneficial to try to direct the person to something than away from something. So rather than trying to direct her away from the TV shows, trying to direct her to some other activity tended to be more beneficial than directing her away. So case 3 is a 22-year-old man who aged out of school. He started to gain weight and had a disagreeable mood and also had difficulty sleeping. He did a history and physical exam, which is the two things that every evaluation needs to start with. And we ordered some labs, including chemistry panel, a CBC, a thyroid labs, B12 and folic acid, and a TTGA for celiac disease. And then he ended up undergoing having a sleep study as well. The sleep study was actually, in his case, actually interesting. He was okay, did not show sleep apnea. So we diagnosed him with depression and with insomnia or sleep issues. Which came first, the chicken or the egg? So the depression causing sleep issues, or the sleep issues contributing to depression? It's probably not A or B. It's probably yes. They're sort of intertwined, and so really trying to address both of them. And so these were addressed with a variety, again, of some of the things we've talked about, both non-medicinal and medicinal strategies to help him get back on track. And again, I mentioned, leaving high school can be quite challenging. And so really trying to, help people in that transition into new activities is so important. So again, for him, we established a new routine. He got counseling, got bupropion or Wellbutrin for depression. And we ended up, sleep persisted to be a problem, and ended up using trazodone, which is an antidepressant that we don't necessarily find works that well as an antidepressant for most individuals, but does seem to help with sleep. So again, that's kind of a whirlwind in an hour. Mental health is obviously a lot to consider, and promoting mental health as well as mental illness. Certainly not something we can touch all bases on in an hour. But again, we do have a lot of information available on our resource library online, with a variety of visuals and videos on mental health, sleep, exercise and physical activity, nutrition, healthy eating, social skills, information about COVID-19. We have a number of articles and webinars, again, on mental health, sleep, exercise and physical activity, nutrition, healthy eating, social skills. We didn't touch too much about that, but it's so important. I think so many individuals with Down syndrome are now getting out into the community more and doing things, working and activities in the community. But sometimes the social skills they learned in school don't translate well, or they have difficulty translating them to what's happening in adulthood. So trying to help them develop the social skills that are so necessary to be out in the community and doing things as for any of us. And when they don't have these skills, it can lend to failure, and failure can lend to mental illness. And so it's so important to make sure that we're helping people with these social skills. And certainly a variety of health promotion, both physical and mental health, directly trying to help promote health, and then certainly information on COVID as well. So again, some information there on both our resources. Our Facebook, we put a post up pretty much every day, or basically every day. And much of it is around promoting health issues or health complications or health illnesses, if you will, illnesses. So certainly feel free to look at our Facebook page. And then we have an email newsletter that comes out regularly as well. So I tried to leave about a half hour for questions, and I think I made it. So
thanks so much, Dr. Scacco. Yes, you guys can unmute yourselves if you had questions, or Dr. Scacco, there is some questions in the chat if you have access to view that. There was two that came in.
All right, let me take a look at those.
Great, thanks.
Okay, so this first one says, how about someone who's 22 and doesn't want to do anything, and now has anxiety in a group of people? She doesn't communicate very well. You have tried so many medications. So, I think this is the key to this is to go, take a step back. What may be contributing to this? Is there an underlying mental health issue? A physical health issue? Does the person have sleep apnea? Does the person have thyroid issues, B12, celiac? look at all those things. Is there an underlying physical issue that's contributing to this? I think is one thing. The second thing, again, maybe a little harder to sort out, and whether you ever figured out or not, whether it changes the treatment, you'd only know by looking. But was there something that happened in a group of people that was a problem? And are we putting her back in the same? I'm saying her, but she. Are we putting her back in the same situation that she found stressful? And would a different social group make more sense, or a different group of people? Or is there something about that group that we could have an impact on that would allow her to go back there with less fear? Can we introduce her more slowly? Can we introduce her back in that group or some other group in a way that she doesn't find as threatening as she apparently does at the moment? Is there something about her sleep that's contributing to this? Poor sleep can contribute to anxiety. And so really looking at all those things would be the first thing. And then, looking at the medication. Again, it looks like she's been on a number of different medications. And so in some ways there is a little bit, it's frustrating for us and for families as well. But sometimes it is a little bit of a trial and error with trying to find the right medication. Certainly the right diagnosis is the starting place, but certainly trying to find the right medication. We do, there's some availability of genetic testing. It doesn't tell you what medication to use, but it does give you an idea of how people metabolize some of these medications. And so if a person metabolizes the medication very rapidly, it may be that really the dose that we're giving them has never been appropriate. Or if they're, they don't metabolize it very well at all. And so a very low dose may start to cause side effects. So again, that may be one way to additionally to help guide the treatment in that individual. So again, looking at it broadly and looking across the way at all the different health issues, all the aspects of mental, physical, and social health is important to try to look at that.
I like how I thank you for that. I asked that question. I also, what you're saying, genetic testing, how do you go about doing that?
So a provider, we've signed up with a company that we use, and then we just the one we use is a swab inside the cheek, then you send it in, and then they send back a report on the metabolism, how these medications are metabolized. Again, there's not complete agreement on this, and there's more data coming in, if you will. So there's this, in some ways, this is not completely proven at this point. So it's certainly not the only thing that I would use, but it is something that I, when I'm finding it challenging for somebody, that we're not having successful medication, it is something I consider to at least add to the process of trying to figure out what the best medications is. And again, these don't tell you what medication to use. These tell you about their metabolism. So it isn't, I swab your cheek and it tells me if you're depressed, you should use X, Y, or Z, or you are depressed and you need X, Y, or Z. It's unfortunately, we're not that far yet, but it is just one other piece of what can be a challenging puzzle.
Yeah, because it's challenging because she has celiac. She does have thyroid, vitamin D issues. We keep up on that blood work to check that.
Yeah, and that's not an uncommon story. Unfortunately, people with Down syndrome do have a variety of co-occurring conditions that are more common, and so people do have, oftentimes will have a number of health issues, and so trying to optimize the health in all those areas is important, because just like the rest of us, if someone's celiac is out at skew, or they're not using their CPAP well, and they have sleep apnea, any of those, if you just don't feel well, it's just harder to get mental health improved. Not impossible, but it's a significantly greater challenge.
Well, thank you. I appreciate all that.
You're welcome. The next one is, I think this is actually a continuation of, we talked about the 4 meds. Okay, I think that was the same question, I think. So next one is, we have a 40-year-old son, and although we have not seen any signs of mental decline, our big worry is the pending doom and gloom of Alzheimer's syndrome. What signs do we look for? So, that's kind of a long time. We've given whole webinars just on Alzheimer's, and we do have some webinars on our webpage about Alzheimer's, a couple of ones, different ones we've given. But let me give you a little, it's not specifically a mental illness, so we didn't try to tackle that on top of everything else today. But I think, obviously, many people that are 40 have that concern. So in general, a couple things. One is Alzheimer's disease is more common in people with Down syndrome, unfortunately, and does occur at a younger age, unfortunately. It is the data that we have today would tell us that it's not common to develop symptoms before 40. So most people who have a change in function before 40, we really want to make sure that we're looking for anytime, really, but particularly before 40, we really want to look for some other cause because there's a pretty fair chance you're going to find something else. And so Alzheimer's disease symptoms before age 40 are not common. Unfortunately, the changes in the brain occur significantly longer or before the person develops Alzheimer's disease symptomatically or clinically. So these changes are going on for a number of years, and that's true for any of us if we develop Alzheimer's disease, that the changes in the brain precede the actual symptoms by years, even decades at times. So that's going on. So at this point, the signs that one would be looking for, certainly like the rest of us, memory impairment, loss of previously mastered skills. One of the things that is probably a little different in people with Down syndrome is that behavioral or psychological changes oftentimes are the first symptom, and oftentimes are, in my experience, are more complicated than they might be in somebody without Down syndrome. So they can be a little more challenging at times. Seizures are more common in people with Down syndrome who develop Alzheimer's disease than they are in other people. As much as 3 to 5 or more times greater in people with Down syndrome and Alzheimer's. Then as the person declines, a number of things, incontinence of urine or stool, difficulty walking, and then ultimately swallowing problems become very challenging. But again, at 40, the average age of onset is in the mid 50s. So at 40, it's on average years away. And again, it's not universal. So although the changes in the brain seem to be universal, for some reason, not everyone with Down syndrome seems to develop symptoms. I think trying to understand that is almost as important as trying to understand why everybody with Down syndrome has plaques and tangles that are the changes in the brain. So what can we do to prevent it? Well, we know that there's a link between sleep apnea and Alzheimer's disease. So certainly, if there's any concern about the possibility of sleep apnea, and even if there's not, it may be worthwhile to consider getting a sleep study and getting sleep apnea treated appropriately. It hasn't been replicated in people with Down syndrome, but there are beginning to be some data available in the non-Down syndrome population that regular exercise may actually help prevent Alzheimer's disease. And again, the rest of these, not great data, but some inkling that these things may help. Certainly keeping the mind stimulated, trying to maintain a healthy weight. Being overweight can contribute to insulin resistance, where we don't manage our insulin doesn't work as well to help manage our sugar. There's some sense that may be contributory. At this point, unfortunately, there's not any vitamins or supplements or what that are definitely been shown to prevent Alzheimer's disease, although that's certainly being looked at, and hopefully we'll have more information as time goes on. Those would be some of the prevention things at this point. On the upside, I can tell you that there's a lot of work going on in Alzheimer's disease, both with people with Down syndrome and without Down syndrome. This is a major health issue in the United States and across the globe. And a lot of people, including in the Down syndrome community, are looking at trying to find answers to this. So hopefully we'll get some, some real answers, before your son develops any symptoms. Next question is, see, this is from the same person. No, this is a different person. So describe, I don't know if this is their son, he's experienced multiple people he cared deeply about passing away, which, is unfortunate reality as we get older, as well as a well-loved pet, all in a span of a few months. Recently, his older brother had evacuated in California from forest fires. He's okay, but that caused a lot of concern. Now he's overwhelmed with anxiety that something will happen to someone else in his family or himself. Are there resources we can use to help him get past his grief and anxiety? Those are good questions. That's really a great question and not an uncommon challenge. Grief is a very interesting thing in all of us, but particularly people with Down syndrome, we often see that grief is delayed, and so the person may not express the grief right after a loss, or may not express. We've seen people not express grief when a parent died, but then the family frog or something died 3 months later, and then they seemed very grieved. Not that the frog was more important than the parent, of course, but that the sort of accumulation of losses. In a sense, not unlike children, a lot of people with Down syndrome see loss as, although most of us probably do to some degree, how does that affect me? And so the loss of someone else, and what would be the impact on his life, or in my case, my life, if someone passed away, and what would that be with regards to my own care and my own needs? So that certainly is something that, reassuring them can be very, very important. Reassuring the person that, other people are healthy, although we obviously, can't promise that no one else is going to die at some point, obviously. And so trying to reassure, trying to spend time together with family that, and do fun things, and try to see things as they were in the past, not to relive the past, but try to remember happy times, and to create new happy times is what I was trying to say. Looking at developing a photo book, if you will, or online or whatever you want to do, of pictures of the individuals or the pets or whatever that had passed away, particularly with that individual with Down syndrome in the photo, and doing something fun, particularly we recommend. So try to turn those sad memories into happy memories as much as possible. So those are some strategies. Again, all the strategies on promoting mental wellness we talked about before, we would certainly encourage: exercise, sleep, healthy eating, etc. Would all be part of it. If it persists, certainly reaching out to a counselor that understands grief, and particularly understands grief in people with intellectual disabilities. There's now some, I think it was published, if I'm not mistaken, a book on grief by a counselor, I think, North or South Carolina, perhaps. And I'm drawing a blank on her name. No reflection on her. I just don't remember names very well. Which may be something to look at. We have some resources on grief on our resource library. So sometimes it does take some professional assistance. And sometimes the anxiety becomes so, if you've done doing all those things, and the anxiety, or even sometimes depression that can occur, become challenging. Then certainly sometimes medications are necessary for anxiety or depression. I should also mention, whatever, how you approach death and how you manage it is certainly something that can be shared. If there's a religious or a faith component to your approach to death, if there's other things that you use to manage it, certainly trying to include the individual in those, rituals, if you will, as well, are all important. And so, again, and what works for one may not work for the other. So, going to the grave and talking to the person, if you will, may be very beneficial for one, but may be very disturbing to another. So, again, trying to figure out how that one individual experiences it is very important.
Thank you.
You're welcome. Those are the ones I had on the chat there.
Are there any other questions from folks outside of the chat, or you're welcome to turn on your microphone and ask? Thank you so much, Dr. Chicoine. This has been really helpful for families and much needed. This topic was requested by a lot of families that we work with in Delaware, and I know Amanda from CPSD said the same thing.
Great. One other thing I would add, if I could, kind of plug for your local physician, Dr. Mary Stevens. She, one of the things we're trying to, Mary and I are both on the board of the Down Syndrome Medical Interest Group. And one of the things we're trying to do is get more information out to healthcare providers and share that information. So it's estimated that only 5% of the people in the United States have access to, or 5% of people with Down syndrome have access to a clinic for people with Down syndrome. And so particularly that other 95%, how are they managing some of these challenging issues? And so one of the ways that through DISMIG we're trying to address that is through sharing information to providers. And so Mary Stevens from locally there in Delaware and Philadelphia and Dr. Peter Bulova from Pittsburgh are given I forget the exact date, but in the next couple weeks are given a presentation. It's aimed for providers, not necessarily for families. But we will share that information. Actually, we're going to post it on our Facebook page and our website, so feel free to look there. And we'll share that information. And so that'd be something to share with your provider if they would like to learn more about Down syndrome. And they can get continuing medical education credits, which we're required to do every year to continue our license. So again, just another way to one of the complaints, I've been doing this almost 30 years, and our clinic's been open almost 30 years. And one of the things I have commonly heard over time is that families feel they're expected to teach their physicians, which is not completely without some grain of truth, unfortunately. So again, this is one way to really sort of take that responsibility out of your off your plate and just share the Down syndrome medical interest group, which providers can go to and learn a great deal, and it's inexpensive to join. So if you're needing to encouraging your provider to learn more about Down syndrome, that would be one way to do that. See, someone said, where can we find these slides? If I did not share them ahead of time, I will send them to, I'm bad with names. There we go. Thank you. No reflection on you, I promise you.
No, it's okay. I referred to you as Dr. Scacco earlier on accident, so it's all right.
That's okay, between the two of us. But I'll send you a copy of the slides so you can distribute.
Thanks so much.
And you're welcome to post these.
Great. Thank you so much for your time this evening, and thanks everybody for being on. We will post and distribute the slides and the recording to those that attended. And feel free to email me if anybody has any questions, and I can get you in touch with Dr. Scacco if you have a direct question for him too. I mean, Dr. Chicoine, sorry. It's been a week. Did it again. But thank you all, and have a good evening.
You too. Be well. Thank you very much for inviting me.
Thank